Alright guys, let's get busy talking about fetal circulation. We're going to start by talking about the path of oxygenated blood and deoxygenated blood through the fetal circulation and talk about some special vascular connections that are unique to fetal circulation. And then we're going to move on to talk about each of these special vascular connections and the high yield details that they like to ask about these vascular connections on the step 1 exam. So let's go ahead and get started by talking about the path of our oxygenated blood through fetal circulation. So we know that oxygenated blood is going to be coming from the placenta because the baby cannot breathe on its own. The lungs of the baby are filled with amniotic fluid, and there's incredible pressure on those lungs since they are full of fluid. So A, it is really hard to pump blood into those lungs, and B, those lungs do not have access to air to get oxygenated. So the whole goal of fetal circulation is to avoid the lungs. So let's talk about how our oxygenated blood from the placenta is going to come through the placenta and how it goes into baby. So if we look over here at our diagram, we're going to see that our placenta is here. And then here we have our umbilical vein in red, and it's basically going to come in here, and then it's going to bypass the liver right here, and this is called the ductus venosus. And then once we get past the ductus venosus, we're going to join with the inferior vena cava, and the inferior vena cava is going to come up here into the right atrium. And then we're going to meet our first special vascular connection here, and this is called the foramen ovale, which is this little hole here that is connecting the right atrium to the left atrium. And the reason why we are doing this is because the right atrium normally goes right ventricle, and then the right ventricle is going to pump blood to the lungs. We want to avoid the lungs, so there's no use in going down to the right ventricle. We're just going to slip right across to the left atrium. That's going to go to the left ventricle, and then we're going to shoot up into the aorta, and everything is going to go to systemic circulation. So this is a really cool mechanism where we can completely bypass the lungs and go directly to the left heart and then up into circulation. So if we review what happened here, we went from placenta, we went through the umbilical vein, up through the ductus venosus, right by the liver, where we met the IVC, and then went to the right atrium. And we talked about the fact that our ductus venosus goes right by the liver, connects with our umbilical vein, and goes to the IVC. And this ductus venosus is going to be called the ligamentum venosum after birth. Then we mentioned that once we get to the right atrium, we go through that special foramen ovale, and that is going to lead us to the left atrium, where we go to the left ventricle, into the aorta, and then we're into systemic circulation, where mom's oxygenated blood can start serving the tissues of the fetus. We mentioned that our foramen ovale is the important thing that allows us to bypass the lungs. This is an example of a right to left shunt, and the closure of this foramen ovale is going to be called the fossa ovalis, and if it persists, which we will talk about a little bit later, we call this a patent foramen ovale, also known as a PFO. So let's go ahead and move on now to talking about our deoxygenated blood. So our deoxygenated blood is going to be coming from our extremities because the fetal tissue has used up all the oxygen that it was getting from mom. So our fetal tissues out here are going to be full of deoxygenated blood, and they're going to come through the vena cava in here to the right atrium. And then once they're in the right atrium, they go to the right ventricle, and then from the right ventricle, you would expect them to pump up through the pulmonary arteries. However, we want to avoid the lungs. So instead of going all the way through the pulmonary arteries and into the lungs, we have this abnormal connection between the pulmonary arteries and the aorta, and this is called the ductus arteriosus. So right here, we can just slip blood into the aorta, and then it's going to go down the descending aorta, and then that blood is going to be pumped back to the maternal placenta, and this is going to be through what will eventually become the internal iliacs, and we call these the umbilical arteries, and they are going to head back to the placenta along this blue path that I'm drawing here, and then we're back to the placenta where we will go on to be oxygenated. So let's kind of review that pathway. We went from the extremities through the superior vena cava into the right atrium, right ventricle, and then the pulmonary artery we kind of stopped short and went into the ductus arteriosus, which connected us back to the aorta into systemic circulation. So we talked about the fact that the ductus arteriosus bypasses our lung, and this is going to become the ligamentum arteriosus after birth. So in general, the two important vascular connections to know here are going to be the foramen ovale, which allows the connection of the right atrium and the left atrium, and then we have the ductus arteriosus, which connects the pulmonary arteries to the aorta. These are both examples of right to left shunts. Now let's get into some fun details that they like to ask about on the step 1 exam. We'll start off by talking about our foramen ovale. So the closure of this is caused by increasing left atrial pressure after birth. So basically when the baby takes its first breath of real air, this is going to change the pressure differentials in the vasculature and the lungs throughout, and essentially we're going to get a big rise in left atrial pressure, and this is going to slam the patent foramen ovale shut. And sometimes this doesn't happen, and this is when we have failure of the septum primum and septum secundum to fuse, and this is called a patent foramen ovale, or a PFO. And this is a really important testing point because a PFO puts patients at risk for certain embolisms. So let's talk about this because it remains open in about 1/4 of our patients. And this embolic risk has to do with the fact that we have this abnormal connection between the right atrium and the left atrium. And let's say someone had a DVT, right? We would expect that DVT to come up the inferior vena cava and go into the right atrium here. And normally that would go ahead and get pumped into the lungs, and the lungs would trap that DVT there, and it would become a pulmonary embolism. And pulmonary embolisms do suck, but they're not as bad as brain embolisms. In the case of a PFO, that clot that was in the right atrium, instead of going to the right ventricle, it can hop right across to the left atrium and then down to the left ventricle, where it can be thrown up the aorta and then up the vasculature and into the brain, where it can cause a stroke. So this is a really serious condition, and they like to ask about this a lot on test day, so it's something to be worth knowing. And if you know the physiology here about the vascular connection, this makes total sense. Moving on now, let's talk about our ductus arteriosus, and I would say this is the highest yield of our vascular connections. There's a lot of questions that are going to be associated with this in terms of a third order question. In our derivatives video, we talked about the fact that this is a derivative of the 6th aortic arch. This is something they might ask on test day. During pregnancy, it's going to be kept open by decreased levels of oxygen and increased levels of prostaglandin E2. And actually, when we have infants with congenital abnormalities in their heart, we can actually use a derivative of prostaglandin E2 called alprostadil, and this will keep the ductus arteriosus open, because when someone has a heart that has abnormal chambers in certain congenital anomalies, it can be beneficial to keep that vascular connection open, and we can do that with alprostadil. Additionally, we will have the patent ductus arteriosus remain open when children have rubella. This is really high yield. This is pathological, and they like you to know that mothers with rubella may often have children with patent ductus arteriosus. In terms of closing ductus arteriosus that are still open, we can use indomethacin, which is going to be an NSAID, and we know that NSAIDs are going to reduce levels of prostaglandins, and it's the prostaglandins throughout the body that are keeping this vascular connection open. So if we get rid of the prostaglandins, we will close that vascular opening, and so we will get closure of the ductus arteriosus with indomethacin. And then finally, if we do have a patient with a patent ductus arteriosus, we expect to hear a continuous machine-like murmur, usually above the left infraclavicular area, and that's super high yield. They love to ask about that machine-like murmur, so it's important to know that if you have a vignette where you have a mother who had symptoms of rubella, perhaps joint pain, and then she has a baby who's born with some cataracts and perhaps a blueberry muffin rash, and then you hear a machine-like murmur, you're like, oh wow, this is definitely patent ductus arteriosus secondary to rubella, and boom, 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 you got your question right, moving on with your points. It's a great feeling to see that type of vignette on test day. Finally, let's wrap up by talking about our ductus venosus. This is a little lower yield, but I want to include it anyways. The right horn of this structure will turn into the smooth portion of the right atrium, and our left horn will turn into the coronary sinus. So I just wanted you guys to know that. In terms of our high yield review, I would say it's important to really just know the path of oxygenated and deoxygenated blood. If you understand this, it will help you understand some of the pathology that's related. And then if I was to put all my crackers in one basket, I would put it in ductus arteriosus, because there are so many questions related to it. If you guys can know that one, I would say that's the highest yield one to know on exam day. I hope you guys enjoyed this video. Can't wait to see you guys in the next one. Bye!